The scams that are out there, there are so many genetic testing companies that are saying, do this to find out if you have EDS. What is real? How do people not waste their money and be safe?
I'm a clinical and biochemical geneticist, and I'm based in Palm Beach, Florida, but I see patients all over the US and as well. Specialize in medical genetics and particular interest in Ehlers-Danlos syndrome. So I've been seeing patients with Ehlers-Danlos syndrome for over a decade, diagnosing, treating, managing, and get the right care and getting to the right people like you. So
It's amazing, and speak firsthand. What you do is amazing, and there's not a lot of geneticists like you. And one thing that I hear a lot from clients is they will either go to a PCP, go to a rheumatologist, go to a geneticist, and be told DS is a social media disorder, or there's no point in getting diagnosed. There's nothing you can do for it anyway, so why do you want an answer? What are your thoughts, and how do you approach things differently?
yeah, I heard all of that, and I think there's a few reasons for it. The first, I think it's a failure of medical genetics, and let me explain why. So first, the average geneticist really is based in an academic pediatric hospital or a pediatric setting. Obviously, Ehlers-Danlos can present in the pediatric period. However, most of the time it's in the adult, after you're an adult. Now, if you try and get into a pediatric hospital for EDS, most of the time it's going to be very difficult. So you're kind of ignored, right? And so genetics hasn't really done Ehlers-Danlos syndrome's justice in that sense that we haven't really been good advocates for it. So when a rheumatologist or some other non-specialist or primary care physician says these things, there's really no one to correct them and really no one to set the record straight on it. I think there's also a problem in genetics. Most geneticists are pediatricians, are happy seeing kids, happy seeing we're used to seeing. When it comes to an adult with multi-system problems, muscle dystonia, multiple already, it's almost too complicated. It's most doctors that see focus on children. Most pediatricians really don't like all of those adult problems that we encounter. I think there's also a lack of education as well, just in general in the medical community. It is getting better, it is improving. Ehlers-Danlos isn't anything new. It's something that's been around for, there's many different subtypes that have been reported. The molecular basis of almost all is known. We're doing a lot of work right now on the hypermobile type, and I think we'll talk about that later. But there's social media diagnosis or anything like that. It's there's many reviewed medical on Ehlers-Danlos management, diagnosis, guidelines, all sorts of things.
Yeah, 100%. So what would you recommend to a patient who is going to a geneticist looking for answers? Any advice on how to get the most out of those appointments and not be left feeling gaslit and misunderstood?
Yeah, and I think you have to make sure that the center you're going to knows about EDS and is help guide you in the right way. A lot of geneticists are really mostly about diagnosis and really don't want to get into too much treatment. Might just say, okay, go see a physical therapist and see you later. You don't look like you have vascular type or any other type, so they won't even order any testing. With that approach these days, because we have such ease of medical genetic testing in 2026, there's really no reason to not do it. Or very reason, let's say that. Virtually on, I'll do genetic testing and good clinical grade genetic testing. Not, we'll talk about that.
We're going to talk about. We're going to get. We're really going to talk about that. That. I'm excited for that part of the conversation. So when a doctor said, and I love that this is what I tell my clients all the time. Geneticists are your answers people. They're not your solutions people. And I do think that it's really good to set your expectations when you're going to a doctor's appointment, because if you're looking for solutions from somebody who's just not going to give that, you're going to set yourself up for failure. And it's okay to have this doctor for answers, this doctor for solutions, this doctor for this, but you need that expectation going in.
Absolutely. I think we really someone you should see at the start. Now, normally we're the last doctor, last specialist you'll see, but it's best to see a geneticist near the start of your journey, which of course is very difficult. So we can help guide you. One of the things that we're very good at is or certainly some, I'll say geneticists, not all. There's some geneticists that, I'll just be honest, are not interested in Ehlers-Danlos whatsoever. So if you that proportion, and it's a significant proportion, then you have people that are happy to help and take an interest, like me. So what we'll do is we'll help coordinate your care. So I mean, this a long time, so I know the right doctors for when you need a GI doc, when you need a good cardiologist, when you need a good neurosurgeon, etc. I'll make sure you see the right person the first time. And so that's called, care. Very important. It's me performing the surgery, might not be me doing the utility study or what is. I'll make sure you're going to the right person for that, and that part of it. There's so many people, so many times you see one, two, three, four of the same specialist. It doesn't help you, and you're worse than you were before.
I would say, yeah, 100% worse. That's something we all the time. And we also have people, what we call building your care team out, because when you have a systemic condition that affects your entire system, you're going to have multiple doctors you need on your care team, and they all need to be at least willing to learn about your condition. They don't have to always be an expert. I do think that we almost put too much pressure on the very few experts that we have out there, and now their wait lists are so incredibly long. If you find a doctor who is willing to learn and willing to listen, that is a really, really good path on your care team as well.
I agree, and patients often ask me, "Do you know I don't know, like let's say kidney issue, which is not a common feature in EDS, but let's just give an example. Do you know a nephrologist or a kidney doctor that knows about EDS?" I'm like, well, you need them to know about EDS. You just need a kidney doctor. Yeah. So, but to it's it's better if they do know, like the GI or the cardiologist. It's better if they do know. But and I'm sure you end up in your practice help guiding people coordinate their care and telling them what other specialists to see. I see that all the time with the physical therapist or some member of the care team, and it's simply because someone help them, right? And who and it can come from many places.
Yes, 100%. And I do musculoskeletal clinicians. We see these patients more often than your typical MD, and so we get to know our patients a little bit better and a little bit more, which allows us to help coordinate their care for their personality type and for what they might need that somebody you see once a year isn't going to understand. Somebody asked early to test a child. I think let's start in general, like how does the current EDS diagnostic process work? And yeah, start there.
So when so just to be clear, I spend 5 days a week seeing individuals that think they have Ehlers-Danlos or have been suspected to by multiple individuals in their team, whether it's a physical therapist, chiropractor, or rheumatologist or primary care. So they'll come in, usually they'll have features already. So we'll go through everything. We'll go through musculoskeletal. We'll go through dysautonomic features, through bruising, subluxations, all that. We'll go through birth history, mast cell related issues. It's not just one area, so you have to ask about everything. And then we'll go through other medical history, family history. Some people have family history, some don't. And just because you don't doesn't mean you don't have it. And then some degree of flexibility. Now, in that, we can look at scales for flexibility. The Beighton scale is a useful scale. It's not perfect by any means. There are significant limitations that have been published regarding the Beighton. And then we'll put it all together. We'll go through diagnostic criteria. I'll go over the diagnosis. And we'll talk about management, things to do, things not arrange genetic testing. I'll find out usually where they're living. I'll have a group of people that I can then, okay, these is a good group for your musculoskeletal. This is a good GI doc if they need it, and then we'll just help based on symptoms. And so that's kind of how it goes. Typical appointment.
Was it your typical appointment?
Yeah, well, yeah, my typical appointment.
Yeah. In the world, it usually goes a little bit differently, and it usually starts, at least from my experience.
I'd love to hear that. I only I do. So
yeah, so that's fair. Yeah.
So, what happens?
So what we usually see is it usually starts with either a physical therapist or a chiropractor or an occupational therapist saying, I think you're hypermobile, go look into this. Then the client goes online, brings it up to their PCP. If they're lucky, their PCP will pull up the diagnostic checklist. They'll go through the Beighton scale. And if they don't pass the Beighton scale, they're going to stop and they're going to tell you, you don't have this condition. I need everybody here to know that that is not true. There is multiple scales to if you're hypermobile. The Beighton scale is a great, easy first screening tool, and it should be the first one that we use because it's easy.
Yeah.
But only test joints, and you have a lot more than 9 joints in your body. And so if you are going to a doctor and they're stopping at the Beighton scale, please find another doctor. And then basically how the process works is we see, all right, you're hypermobile, you have 5 or more joints in your body that are hypermobile. Then the second part of the checklist is a bunch of very specific symptoms. If you don't have those specific symptoms, you're kind of diagnosed with at this point. If you do have those specific symptoms, then they'll send you to get blood work to rule out all of the other types of EDS, and that's how you get diagnosed with hEDS, is how we're seeing it in not clinics like you. That being said, how important do you believe a true clinical diagnosis of hEDS is?
I think it's very important because otherwise a lot of the patients are simply left in limbo. There's no clear diagnosis. Hypermobility spectrum. Well, I don't really the term hypermobility spectrum disorder. Spectrum disorder is typically used to describe psychiatric conditions. I don't think it's a good terminology to use to describe a condition, vascular fragility and musculoskeletal. So I don't typically look to diagnose people with hypermobility spectrum disorder. It's either hEDS or there's some other thing else, tissue. Well, I look broadly. I don't just look at Ehlers-Danlos genes. I look at other genes, Marfan syndrome, other less common conditions. But back to on how important is it? Generally in genetics, having a diagnosis helps massively, and often it's something we really try to do very early on with a patient's journey. The reason for that is when you try and get therapy, let's say you try and go to chiropractor, try to go to physical therapist, try to go somewhere, anyone, they'll ask you, all right, what's the diagnosis? And they don't have one, and so you don't progress into the next step because you don't have a diagnosis. So getting into the care that you need, it's critical. Our system is set up. It's very important to diagnosis.
And I think musculoskeletal clinicians specifically, so chiropractors, physical therapists, occupational therapists, if you're seeing the symptoms of hypermobility, treat them like they have this condition, even if they don't have the label, because they need the solutions and you can give them those solutions even if they don't have the definitive answer yet, while you're trying to help them find that definitive answer, because it's not always so easy to get that answer in this day and age, unfortunately.
One thing I find people are often scared to give a diagnosis or even suggest a diagnosis. I don't know why that is. The whole point of even that one-page checklist that's developed for hypermobility EDS was for non-specialists to feel comfortable saying this is hypermobile Ehlers-Danlos syndrome. So the point now that it's something that's only in the pair of a specialist, that's missed of that one-page checklist. And now, don't get me wrong, there's issues with a one-page checklist for a very complex condition, right? But the purpose was to to get people more confident in this diagnosis being accurate, again, to help further their care, right? Which is the goal at the end of the day.
The scams that are out there. There are so many genetic testing companies that are saying, do this to find out if you have EDS. What is real? How do people not waste their money and be safe?
When it comes to the genetic testing, there's what I would call recreational genetic testing. For example, you go find out where your ancestors might have been from, and then there's what I would call medical or clinical grade genetic testing. That's a lab that has satisfied requirements set by lab regulators, CLIA, the American Society of Pathology. So these are labs that are regulated and tested regularly on their accuracy, and that's the key point of it as well. So, for example, they'll get a sample sent to them and say, tell us what this DNA sequence shows. And if they don't get it right, well, that's a problem. So they're checked as well. And so what's how is this confusion between the two. Now you'll have recreational data that you can just pull from the recreational lab. You put it in a $5 upload, and you'll get a kind of readout of your other data. That's proven to be inaccurate and wrong by multiple medical studies. And the literature's out. Many clinical labs have actually done that themselves and taken what what's and compared it to their own, and it's just wrong. It's not even accurate. So we can't trust that. And so that's the issue of the sequencing. That is it if the at this point in the DNA there's an A rather than a G or a T or a C or whatever, right? So that's the first issue. This issue comes, which is actually a bigger issue, in the interpretation. So the sequencing is almost the easy part in genetics. It's the interpretation that's the hard part. So you really need a lab that has all the steps, including at the end a sign out by a trained geneticist, molecular geneticist usually. And if they don't have, you can't trust it. And you see a lot online, buyer tests online, not physician involvement, and you get this kind of huge readout of just computer generated reports that have real limited, if any, meaning. Many patients come to me with these reports and say, I'm worried about this and the vascular DS gene, and I'm worried about I've got vascular DS, which I would be worried too. And almost always, well, actually, I've never had a case where when I do clinical grade testing, it's actually come back as they have a variant in the vascular DS gene. So it creates a lot. It wastes money. Patients sends them in the wrong direction, and I think it needs to stop.
And it drastically needs to stop. And to the marketing companies that are looking at this vulnerable patient population and profiting off of them,
it's disgusting.
It's disgusting, and you are harm, and I hope you see this. And I am talking to the sequencing one that I see on Instagram every single day. That is completely scamming you, and do not fall for it. Do not spend your money on it. It's not worth it. It is going to cause more harm than good.
And it's also ignored experts like me. When the patient sends reports, the raw data, I don't even look at it.
Right.
I know it's wrong. And the funny thing is, when I tell the patient that, I've never been challenged. It's never, and patients never said, no, I think it's right. Almost know it's wrong.
Yeah.
I think they know it's wrong.
Like in musculoskeletal care all the time, and it's true everywhere. Like if it seems too good to be true, it probably is. Like there's a reason you need to go to a doctor to get a diagnosis. Like it should not be a one-click Instagram ad that's going to tell you have a genetic condition. That just doesn't feel right because it's not right.
Absolutely, yeah, absolutely.
What in the genetic world that you're aware of, and how is this going to impact our community, if at all?
Yeah, great question. So I think first we have to improve the criteria for Ehlers-Danlos syndrome. When it comes to the hypermobile type, most common type, there's issues with the diagnostic criteria, including lack of weight comes to the dysautonomic features, sometimes which are the worst feature they have, and also the association with stuff. The Norris Lab, for example, good friends of mine have done great work in this area, and so there's people to get together and look at this and create better criteria. The other thing is we haven't found the gene of the hypermobile type, and just to talk about that, I think it's very important. I think one of the issues that is with hypermobility DS, in the sense that some people think that means the condition may not be real or something like that. So just to take a step back and provide a very simple history lesson in genetics. If you go back 10, certainly 20 years ago, we didn't have a gene. We didn't know the genetic basis, and it was all clinical diagnosis. That's normal. So suddenly, and it's been incredible in that short time span in medicine how much things have changed, and it's actually amazing that it's gone to think that clinical diagnosis somehow makes the condition not real. It's almost bizarre. It is bizarre. So that's one thing. The second is not with EDS, but with other genetic conditions. You can have a condition where we know there's a single gene that causes it, and we know biochemically with clinical presentation, with other criteria, that patient has that condition. It's not in question. And when we do genetic testing on that gene, we can't find the change. And sometimes it's maybe you find it at time, sometimes 70% of the time, whatever it is. So we don't have perfect genetic testing. Genetic testing is improving, but there are areas in the genome. There's sort of genetic variants we struggle to look at, struggle to detect, and it's a technology is obviously getting better with better sequencing technology, faster, cheaper. So it's all improving, but it's not perfect. And so these are reasons why we haven't necessarily found the genetic basis, or I think probably bases for hypermobile Ehlers-Danlos. It will happen. It's just going to take time. But I don't think it's something that you suddenly think something isn't real or doesn't exist because we haven't got the technology to change. And also with genetics now, we're really focused on single genes rather than multiple genes working together to cause medical conditions. We're really in the early stage of that, and it's quite possible there's a multi-gene element. Really, not at the stage to be able to detect reliably.
We need better clinical decision skills and a better way to clinically notice hEDS at this point. The diagnostic checklist is not doing it. Its intention was good, but it's not encompassing what we're seeing in real world. And it's followed too strictly by clinicians to the point where if you don't meet it exactly, you're gone. And it's so strict. It's 12 like most random symptoms on the planet, like aren't even the most common that found in the Norris lab paper that just came out. And so I really, really do hope that we get a revamp of how to clinically make this diagnosis. That is a big, big barrier currently that needs to be broken like yesterday.
I agree. Yeah.
All right. Questions for me or anything you wanted to talk through that we haven't talked through yet?
We talked about the main things: the importance of diagnosis, the utility of good genetic testing, the limitations, usefulness and limitations of the Beighton, and I suppose one thing with testing, sometimes we have these variants that are found. They're called variants of significance. Yeah. That's not a diagnosis, and doesn't mean you have. Most variants of uncertain significance are reclassified as benign variants in the next 3 to 5 years after. There's many studies that show that. Finding a variant of uncertain significance and let's say, a vascular EDS gene or something like that, you automatically have, or even likely have vascular EDS. It's much more likely you don't. And this is why people really need to be seeing an expert in genetics. The average physician, rheumatologist, cardiologist, they really lack sufficient training in genetics to be able to figure that out. Look at the genetic informed explanation or provide informed genetic counseling on it.
How often do you find adults coming to you and they actually have vascular EDS without warning signs earlier on in life?
It's extremely uncommon, thankfully, and I've had a few with vascular EDS. It's thankfully very, very rare, and it's not something that is. Usually, there's some factor in the 20s or 30s that brings it to attention. So what I'm saying is, if you're 55, 60, you haven't had a major vascular event, you've self-selected away from having vascular EDS. So it's much less something you're worrying about to a significant degree.
Yeah. What would you say for 40-year-olds?
Again, would have expected something to happen around that time, and I think it's easy to do the genetic test to rule it out. So we do it all the time, and it's a comprehensive, easy test. It takes 10 days or so to get back. It's a cheek swab that they send to the house and they return it themselves. They don't, not even a blood draw. So it also reduces a lot of anxiety and worry that even though you have an expert saying you don't have it or you don't have the features of it, to have that extra reassurance of a negative genetic test, I think is powerful and has a lot of personal utility for patients.
For sure. Awesome. All right. Any chat? I don't see any yet.
I think there was one about testing a child.
Yeah. How early is a child?
Yeah, good question, and it's not a I tell on a if I'm asked around age 7, but there's exceptions. So one could be strong history, but really, if a child is around that age, having lots of joint issues, having joint pain, or maybe some other features, it's reasonable for them to be evaluated and checked. Now, if they're 5 and having that, I'm not saying no, just wait till they're 7. So there's exceptions, but that's kind of like the age goes into it.
I want to emphasize though, they have symptoms because I do see a lot of the time a lot of parents get scared because they see hypermobility. Hypermobility is not symptoms, and kids are naturally more hypermobile than adults. And
Yes.
just because your child is hypermobile, that does not mean they have hEDS, and that does not mean that they need genetic testing right away.
Correct.
If they are not having symptoms, they're not complaining about pain, they're not complaining about really anything, do not instill fear in your child. I think that's really important.
So absolutely right. And let's just talk about hypermobility. I think that is a misunderstood topic. And to your point, almost all even all children are. Many adults are hypermobile.
Mm-hmm.
Mobility is, as you know, you can say better than that. It's a spectrum, and it's a bell-shaped curve. There's a normal distribution. So there's some people that are on average are going to be more flexible than general population. Some people on average are going to be less flexible, and you're going to have people on the 97th percentile for flexibility or for hypermobility for mobility, and you're going to run the third. That just because you're on the 97th percentile for mobility does not mean you have Ehlers-Danlos. So,
and it's a big problem on the internet because a lot of people will see, like, there's a trend going on right now that if you can put your palm on your shoulders, that means that you're hypermobile and you have a connective tissue disorder. Like, no, that's not how this works.
A lot of misinformation.
Yeah, there's a lot of misinformation. I know we're not on the. Yeah, we're trying to get Dr. Atwell.
Yeah.
So get ready for lots of misinformation there. But it's a big problem, and asymptomatic joint hypermobility is insanely common, and it is not something you need to worry about if you're not experiencing symptoms. That being said, with the recent paper from the Norris lab that came out, we do know that there are some things that might trigger somebody who was once asymptomatic to becoming symptomatic, and those things are an infection like a virus like COVID, Epstein-Barr virus, trauma, both emotional or physical, like a car accident, and we're also seeing postpartum being a trigger as well. And so being aware of these triggers is really all you need if you are in that asymptomatic category. You do not need to go down rabbit holes just because you're extra bendy. You don't.
I think a lot of these, I've seen in my clinical practice, a lot of it, if you look at the common pathway, there's some degree of physiological stress, inflammation that's occurred, and then some sort of insult to the body, and that's caused something to, it's called reaction in some way, or brought something to the surface that was kind of being managed.
What are symptoms to notice that may be concerning, and how do you help?
So tell the parents all children complain of pain. Now and again, so a child will say, oh, this hurts, that hurts. They've forgotten about it. If you don't mention it the next day, don't worry about it. If a child is mentioning or telling you that the joint day in, day out, week after week is causing them problems, well, that's something to take seriously. Taking them to the pediatrician and the pediatrician telling them it's growing pains is I don't like that. I'd like it to be further, particularly if there's a family history or some other reason to suggest Ehlers-Danlos. But again, it has to be contextual. If it's one time and it's maybe they had a fall on that joint and that's fine. But if it's something that there's the blue and multiple joints and it's all been attributed to growing pains and there's a family history of Ehlers-Danlos, I think we need to be doing better than that.
Yeah, and I want to also encourage, if you are going to go down that road, finding someone like Dr. Atwell, because a lot of clinicians will not even look at a child until they're 12 years old because of the EDS Society's new children criteria that they created. So that's just something to be aware of. Very good question. When hEDS genetic testing becomes available, will there be any benefit of getting additional testing done if you're already diagnosed?
Yeah, it's a good question. I think there's some utility, but there's also, let me talk about that. So, not danger, maybe it's too strong a word, but as you get to understand the of condition over the years, sometimes knowing the gene change, or if it's in this gene compared to that gene, or this particular variant compared to that variant, that can help you understand the natural history of the condition or what to expect, and it can give you some ideas. Now, when it first comes out to be there, the other thing is we're not going to have a complete of the genetic landscape for hEDS at the start, and there's a risk that you do the testing and you don't find anything. And in fact, probably most people, that's what will happen, right? So that doesn't mean you're suddenly less of an individual with hEDS, just because you don't. And someone that has that particular gene or those particular variants has it more than you. So we just have to be careful with that.
Yeah, I think it's going to be very interesting, and we're going to, as clinicians, have to really explain multiple times and in different ways that is all new, and what's true today might not be true tomorrow and in a couple of weeks. And so living in the gray and not being so black and white right now is really, really important.